This video will demonstrate sampling techniques for thyroidectomy specimens. Be sure to be familiar with AJCC guidelines on the CAP website before sampling any specimen. As you can see here, based on the most recent AJCC guidelines, the staging is based on tumor size and extent of invasion and is different for different tumor types, so we will pay close attention to these metrics. Here is the final gross description for the specimen you are about to watch. It is here for your reference, and it will be shown again at the end of the video. Check the patient's medical record and note any prior FNA or frozen section diagnoses. Be aware that some patients may have multiple FNA results from different areas of their thyroid, and that the different FNA sites from the same thyroid may have different diagnoses. First, weigh the specimen. Then anatomically orient the specimen. For total thyroidectomies, these specimens are usually easily oriented. The flat and slightly concave aspect of the thyroid lobe is posterior, and the isthmus will be present inferiorly and medially, attaching the two lobes to one another. For hemithyroidectomies, the flat and slightly concave aspect of the thyroid lobe is posterior, and a small nub of the isthmus will usually be present on the inferior medial aspect of the lobe. On occasion, the surgeon may have placed sutures for orientation on the specimen. Examine and describe the external surface of the specimen. Measure each lobe in 3 dimensions and measure the isthmus in 3 dimensions. Specifically, look for adherent skeletal muscle. If present, this will usually be on the anterior surface. Look for any nodules that may represent adherent parathyroid glands. If present, they will usually be attached to the posterior surface. Any potential parathyroid glands identified should be noted and submitted for microscopic examination. On occasion, lymph nodes may also be attached to the external surface, and these should be noted and submitted as possible lymph nodes. In this case, the external surface is variegated red, pink, and purple, with a thin fibrous capsule that shows no adherent structures. Ink the external surface of the specimen. The inked surface is the only margin of total thyroidectomy specimens. In hemithyroidectomies, the inked surface and the transected edge of the isthmus are the surgical margins. Seriously section each thyroid lobe and the isthmus using 0.4 centimeter intervals and cuts perpendicular to the long axis of the lobe. Lay them out in sequential order so that the cut surfaces can be examined. With total thyroidectomy specimens, be sure to keep track of right versus left. When you examine the cut surfaces, note the following features: presence of any nodules, whether single or multiple, location of any nodules, example right lobe, left lobe, or isthmus, characteristics of any nodules present, including color, consistency, encapsulation, circumscription, infiltrative borders, and solid or cystic components, and the presence of necrosis and or hemorrhage within a nodule. For encapsulated lesions, the entire capsule should be submitted for histologic evaluation. Always measure any lesions in 3 dimensions and correlate your gross findings with any prior FNA or frozen results. In this case, there was a well-circumscribed, tan-white, solid nodule in the right lower lobe measuring 1.0 by 0.7 by 0.5 centimeters and abutting the black inked surface. Take a photograph of the serially sectioned specimen that demonstrates the cut surface of the nodule or nodules of interest. Once again, here is the final gross description for the specimen you just watched.